So now we're going to talk a little bit about patient safety plans or suicide safety plans. So you may remember from Dave Job's TM's book that part of his treatment, a big part of his treatment, is giving the patient a card that describes ways to help manage the suicide risk, help manage the emotions, and help the individual get through the distress that they're feeling, while also providing them with adequate resources so that they have the ability to reach out and get help as they need. So this is actually done in many different treatments. It's pretty much ubiquitous at this point, and it's really replaced those no suicide contracts that I've mentioned are not the way to go. So this is a template of a safety plan. I want to first give credit and also just tell you about a resource. This comes from the SPRC, so that's the Suicide Prevention Resource Center. They're a fantastic group that I really hope you get to know, but they have a ton of great resources on this website. This is just one of them. So if you need anything relating to suicide prevention, SPRC's website is a great place to go. But now that I got the shout out to SPRC done, let's talk through what the safety plan actually includes and how one would use it. So the first thing is individuals need to know their warning signs. So often there are things that happen that predict the onset of suicidal thoughts and behaviors. Maybe the person has a lot of trouble sleeping. Maybe they feel very agitated. Maybe it's when they get stressed or when they fight with a spouse. So with doing your suicide assessment and working through understanding the suicide risk, hopefully you as the clinician will get a good feeling for what is it that actually leads to this individual becoming suicidal. So what you do here is you first write down the warning signs for this individual that a crisis may be developing. So the thought here is that if you do this, hopefully you can help the individual identify when they're at risk so that they can intervene before it gets all the way to a crisis. So that's the first step. Now, the second step is learning on how to cope. So here you'll see we have internal coping strategies, so things I can do to take my mind off of problems without contacting other people. So this can be our relaxation techniques, as it mentions. What I usually try to do is I use what we call behavioral activation, and Job's talks about this as well. Basically, we want people out doing things because we know that the more you do things, the more energy you have, the better you feel, the less likely you are to be suicidal. So I usually will tell people, I want you to go out and do something, whether it's walking, whether it's going to the mall, people watch, whatever it is you like to do. Try to do it. Try to be around people when possible. You don't want to just be somewhere on your own lonesome, but do something that is active that helps get your mind off of things. So that's the second step, is trying to help the individual learn to cope with the distress on their own using these strategies that they can just do on their own. Now, the third step is you want to reach out. So there are people that can help, provide you with a distraction from what's going on. So with this, often when someone's suicidal, you're not thinking well. You're not thinking well. You're not able to problem solve. So you need to make this as clear cut as you can ahead of time. That's why you have 3 people, names, phone numbers. Or I guess you just have 2 names, phone numbers. The second 2 are places. But you set this up ahead of time. The first person I'm going to call is Aunt Susie, and here's the phone number. So it's very easy to follow. You don't have to do problem solving while you're suicidal, which is important. And then places, of course, are places to go. Again, you want places that the individual's not going to be alone. Well, I shouldn't even say preferably, not going to be drinking. You don't want to be drinking. But places where they'll hopefully be around other people. Because again, as Job's mentioned, and as Joyner points out, that interaction with others is really a need for us. Now, let's say this doesn't work. This, you're not getting anywhere with this. Then the next step is people whom I can ask for help. So these are going to be family, friends, things like that. Again, we're putting the name and the phone number in ahead of time, so there's no question of who to call, what order, what number. You just go down the list. And then the next step is professionals or agencies that I can contact during the crisis. I actually will typically, when I'm working with a suicidal client, I will have them call the Lifeline before they call me. And the reason I do this is, I have a lot of faith in the Lifeline, honestly. But again, I want my clients to learn how to manage distress when I'm, no longer seeing them. So part of that managing distress can be calling the Lifeline. That's something that will always be there for them. So I usually have that be ahead of me, just because I want them to try to do that reaching out. And if that's not helping, then certainly I want them to call me, but I want them to make that step first. So you have the Lifeline, then you have the clinician, and Job's talks about this as far as, you have to decide what your normal operating procedures are and make sure the client knows that. So some people are only available 8 to 5. Some people are available anytime. The client needs to know about that. But really, the client needs a way to be able to contact you as the therapist. If you're an 8 to 5 only practice, you probably shouldn't be seeing suicidal clients. So typically what I will do is I will give out my cell phone number to clients who are suicidal so that they can get in touch with me anytime. Just because, as Job mentions, the client has to be fully in the car, and you do too as a therapist. You have to be fully on board with treating this case, and that's part of it, is being available to help with emergencies. Now, maybe for whatever reason, they can't get in touch with you. Your cell phone's dead, who knows why. You always want to have local emergency services listed here, both numbers as well as the address. So the person knows, okay, if I can't get in touch with, Dr. Nadorff, I need to, call 911, I need to go to the hospital, so they know what they need to do. And then the last step is, if none of this has helped, if you're still suicidal, you call 911, you get it so they're coming, and then you make the environment safe. This may be going to the hospital for a couple of days. This may be, being with other people, maybe spending a couple of days with family members. Whatever it is, you got to make your environment safe so you're not going to act on suicidal impulses. And then the last thing here we see is that, kind of like how Job says the one question on, the one thing that would make life worth living, it's kind of the same thing. So it's, what is the thing that's most important to me and worth living for? Just to help the person remember why they're going through all this. That, when you're suicidal, it feels helpless. It feels absolutely horrible. You don't see any hope, any glimmer of hope or any way out. It just doesn't feel like anything will ever get better. So this is something that can help the person realize that there's something to live for, even if it's, my cat. What would happen to my pets if I weren't here? Whatever it is, whatever the person is whatever they're living for, whatever is worth fighting for their life for, you put here to help them remember when they're at their worst, why it is they're going through this and why it is that they need to stay living. So this is the suicide plan, and it works really well. I find I like it again because it helps the client learn how to handle their distress while also providing them with all the resources they need so they're not going to fall through the cracks.